This is a short presentation on a case we operated yesterday early morning. We discussed the rationale behind the approach and the prognosis. Mr. BL, a migrant laborer, 32 years of age, sustained injury to the back as a result of a fall from a tree. The impact was directly to the lumbar region. He fell flat on his back. On examination, he was hemodynamically stable. There were no features of head injury. The thorax and abdomen were essentially normal. He was unable to move the ankles or feet after the fall, and there was a total loss of sensation below the knee. It is not below the ankle, below the knee. The patient was catheterized, and the urine was seen to be clear. This shows the MRI of the patient, a whole spine screening which was done. The lumbar 3 vertebra was completely shattered and the spinal canal totally compromised, suggesting a significant caudal injury. The lumbar vertebra 1 was also fractured and considered unstable. Steroids were administered to the patient in addition to antibiotics and pain relief. The role of steroids in cauda injury is controversial. He was taken up for immediate surgery. The rationale for immediate surgery at midnight was that this was a cauda injury, and unlike a spinal cord injury with this kind of compression, the results could be heartening. Pedicle screws were passed in D12, L2, and lumbar vertebra 4. A laminectomy was done at lumbar vertebra 3, and part of the lamina of lumbar vertebra 2 was also nibbled. The dura could not be seen. It was totally shredded, and the roots were lying free. Some of the roots of the cauda were actually seen to be disrupted. The procedure which was undertaken was a distraction stabilization of the spine. Closure was done in layers, and dural closure was not really attempted. We would have liked to keep some fat and glue, but fat was not available because the patient was absolutely thin, not an ounce of fat on him. This is the post-operative X-ray after the stabilization. A quick overview. How do we decide on surgery for a spinal injury? There are two basic indications. One is, are neural elements actively compressed? And the second is there instability? In this case, the neural elements were compressed and there was instability, and the patient was taken up immediately. Although the injury, if this kind of an injury had occurred in the spinal cord, we'd have probably waited till morning before operating. The timing of surgery depends on few things. One is the patient hemodynamically stable? One of the reasons why we sometimes delay a spinal cord injury due to a spine fracture is that the patient's blood pressure might not be stable because of spinal shock. Relief of compression, if achieved immediately in the cauda equina, can have heartening results. Dural repair is often not possible in severe injuries. I have operated on gunshot injuries of the spine involving the cauda equina, and again faced a similar conundrum of a total lack of usable dura to repair and reconstruct the spinal canal. Stabilization for the spine can wait till the patient is stable. The timing of stabilization is basically to facilitate early mobilization. So a person with multi-system injuries in polytrauma who is likely to be bedbound for some time. The stabilization might even wait for a few days till the patient is stabilized from other angles.